But I want to welcome Dr. Avedijian. So Sean has talked at one of our previous conventions, and it was when we had a virtual one during COVID. And so he talked on this same topic, but now, of course, it has a different twist to it because now he's talking about some different meds associated with the pandemic. So Sean comes to us from Omaha. He's a colleague of mine, and I'm going to let him tell you a lot more about his, what he does at the university and a lot more about him. But please help me in welcoming Dr. Avedijian.
Thank you. Thank you for the introduction. So hi, everybody. I'm sure we've all heard enough of COVID throughout the years, so I'll try to make this fun. I'm going to try and ask you guys questions just to get some opinions. We might have some inpatient techs and outpatient techs. It would be good to get different perspectives to see what your experiences are with some of the medications that we're going to talk about. So a little about me. I'm an assistant professor at the University of Nebraska. I did my training out here, actually. I went to school at USC, and I was an intern pharmacist at Citrus Valley Medical Center, back in West Covina. And I actually have my former clinical coordinator here because he wanted to watch me. Thank him for getting me here and putting up with me during the Vanco dosing and the warfarin dosing. So a little about me and my research. So I actually do a lot of antiviral pharmacology research now. So HIV, COVID. So I'm not able to just talk about this given research I've looked up, but we have some ongoing studies on some of this stuff. But again, I'm just going to focus on what's on the guidelines and what's recommended by the NIH. So no disclosures. And the objectives, kind of just a brief introduction to COVID. I know we've heard a lot about it. Some updates, potentially. When I first gave this lecture to my students, it was like 20 slides. It was great. But then each year, it got worse. And I had to redo everything. And now it's turned into like a 70-plus lecture that I give to my students. And unfortunately, it's funny, all the drugs that I initially talked about had to be updated because a lot of them, weren't used anymore, or mutations happened and things changed. So this has come a long way from when I first made this lecture. So then we'll discuss the pathophys briefly on COVID and kind of what it does, why it does, and why it's so severe in terms of the reaction in patients. The treatments available. It's getting better. I'll tell you, there are more treatments in the pipeline that are coming, specifically antiviral agents, but we'll talk about briefly the ones that are available now. Just recently, actually, last week, Paxlovid got FDA approval. So when I made this lecture, it was still under EUA, Emergency Use Authorization. And then we'll talk a bit, so not that it's my favorite, but I think it's one of the most promising treatments right now, Paxlovid. Unfortunately, it does have some potential drug-drug interactions associated with it because of its ritonavir component, and we'll talk about that. So we'll talk about a little bit things about the drug-drug interactions, what to look out for, some resources that are available to us free that we can use to see what we do in patients that may have these interactions. So I think this slide kind of hits us all really hard, right? This was a microbiologist, Joshua Lederberg. He won the Nobel Prize, or shared the Nobel Prize it was a while back, before I was born. But he's credited for this quote: "The single biggest threat to the man's continued dominance on the planet is the virus." So I think we can all say that he was probably on the right track when he said that. So what is COVID? There are currently 7 known coronaviruses to exist. Again, known, that can change, hopefully it doesn't. Normally they're mild to moderate disease, respiratory viruses with respiratory symptoms. At one point in our lives prior to this COVID pandemic, we had probably caught some form of a coronavirus. But again, it was mild to moderate, it wasn't severe. Unfortunately, the bad guys, MERS and SARS, are known to be associated with more of a severe illness and death. Those are the ones that kind of get the bad rep. They do infect animals. It's not solely to humans, camels, cats, and bats. Interestingly enough, I had to look this up. Back when I was giving this lecture to my students, the first animal to be infected known was a tiger in New York, Nadia, at the New York Zoo. But because of their expression of ACE2 receptor, and we'll talk about this on upcoming slides, they don't react as severe as we do. The virus uses a specific receptor to get into our body and to cause all the havoc that it does. But not all animals and species express that same expression of that receptor, the ACE2 receptor. So for animals, it's not as severe as it is for humans. The virus has evolved to survive and reproduce in other animals. We'll talk about some of the theories and can jump from species and cause serious disease. So again, it's a respiratory virus, single-stranded common RNA virus found in mammals, birds, and reptiles. We'll talk a little bit about the different types of virus. There's an actual classification that they use for viruses, the Baltimore classification, and it's specific to the type of DNA material that it comes with. Viruses are very small and simple, but they're actually a lot more complex than people think. And they've kind of evolved to do very interesting things in the body to reproduce and to infect. So we'll talk a little bit about that. Their genetic analysis shows potential relation with 2 bat-derived strains. A lot of the studies that were done were in bats for the coronavirus, but specifically in the Wuhan, in the lab that they were known to be doing this, the bat studies with this virus. The common theory is that it jumped from an intermediate species like a pangolin. It's like an anteater type looking animal, so from bat to pangolin to humans. And they found that there was actually 1 amino acid difference in a protein between coronaviruses from pangolins and those with humans. But again, I think it's safe to say that the real origin of it is still unknown. The first, as we know, it's first identified in Wuhan, 3 patients that presented with pneumonia. It's gone from an epidemic to a pandemic, and I think it's safe to say now that it's transitioned into an endemic where we're going to have to be dealing with these, similar to like the influenza, these seasonal fluctuations, and potentially seasonal flu shot, or COVID shots, similar to the flu. So I grew up with watching the X-Files, so the truth is out there. Was it a bat to intermediate animal to human jump? That's potentially a common theory. Was it just straight bat to human? Another potential theory. Or was it contamination from frozen food? Another one. Not as popular as the first 2, of course. And more recently, and I put this in here not to be like a conspiracy theorist, but this was an actual announcement from the government and from the U.S. Energy Department that there's very much evidence to show that this is likely a lab leak. So did it happen on purpose? No, but potentially given the lab safety measures, it could have gotten out. But again, the truth is out there, and we'll probably never know the real truth. So pathophysiology on it briefly. Lungs are most infected. It's a respiratory virus causing pneumonia. Again, the goal here and the thing to think about is the ACE2 receptor. Our lungs express the ACE2 receptor in abundance. So the virus uses it to get in. However, it's not just solely for the lungs. It can infect any part of the body that expresses the ACE2 receptor. Recently, you guys might have heard of this long COVID, or PASC, P-A-S-C, post-acute sequela of coronavirus. And that's all happening because, again, ACE2 is not specific to the lungs. You guys might know some medications that we use to ACE inhibitors, right? Like the Pril endings. And interestingly enough, when coronavirus was first becoming a thing, they looked at ACE inhibitors as a potential therapy because there was nothing available. This is before remdesivir got EUA, thinking like all the way in the back. So again, it's found in the heart, kidneys, GI tract. I have my own hypothesis about long COVID, but not the point of this lecture. Happy to talk about that with anybody if anybody wants to talk after this talk. And the virus uses the spike protein on it to connect to the ACE2 receptor and enter the host. Causes systemic hyperinflammation, and you get elevated inflammatory biomarkers. So again, the virus itself, important to note that it's not the virus that's killing you, right? It's the inflammation that's occurring in the lungs because of the virus getting out and causing all that havoc. So, what do people that have COVID usually die with? Open to the public here. Breathing issues, right? They can't breathe, they need oxygenation. So again, it's that hyperinflammation that's going on. So I always tell my students, thinking about treatment, think about does it make sense, right? If we have a disease state that's caused by inflammation, what do we think is going to be good treatments for it? Anti-inflammatories, things that actually make sense. I'm not going to talk about hydroxychloroquine here, Plaquenil, azithromycin. They've all been looked at. Studies have showed that there's really no benefit in those medications. Azithromycin's been used a lot for its anti-inflammatory properties in other disease states, but again, right now it's not recommended by the NIH or the IDSA guidelines for treatment of COVID. So a little bit about the pathogen. I'm not going to spend too much time. It's just here as an FYI. You see the virus attaches to the ACE2 with the spike protein. It gets in and it does its job. What does the virus want to do? It wants to make proteins and it wants to replicate. It makes those proteins so that it can make a new capsule and they can get out and go make more versions of itself, virons. So kind of looking back at that pathophys specifically in the lungs, what happens? Well, when it exits that cell, it kills the cell. By killing the cell, it causes inflammation. Inflammation happens, you get this release of these inflammatory biomarkers, you get all that gunk in there, you get inadequate gas exchange. Inadequate gas exchange, the patient can't breathe. As you can see, it kind of spirals down forward and can lead to poor prognosis. So initially when coronavirus was a thing, we were dealing with a wild-type virus. That's the official term for when, the first version of it, the wild-type. Then we got variants, and it turned into like a sorority fraternity house with all the different names that we're dealing with, Omicron, Delta. And I don't even know where we're at right now. I think we're on some version of the Omicron. With and they have different subtypes like B14, and they keep putting numbers to it to show the difference of where it came from. There's this nice little picture there that's probably too hard to see, but again, if you guys blow it up, it kind of shows the whole genotype of it and kind of where all the different strains came from and how they're related. And you can blow that up and kind of take a look at that. So again, I talked a little bit about that. The goal of a virus has two main jobs. Is one, make viral proteins, and two, make more copies of itself. So this Baltimore class that I talked about earlier, so COVID is a class 4. So what does that mean? That means it's a positive sense single-strand RNA virus. And there's positive sense double-strand, there's negative sense single. And these are all used to classify with the Baltimore classification. So it's kind of interesting because coronavirus comes with the ball that has a positive sense single-strand RNA. That's the same thing as messenger RNA. They're the same thing. So what does that mean? That means as soon as it enters the cell, it can go make viral proteins. It doesn't need to make mirror images of itself, going from positive to a negative sense, and then use that to then, to turn into an mRNA to make protein. So it can go in and it can just do its job right away. So I think, I tell my students that's one way of looking at it, why it's so contagious, because it gets in and it can go ahead and do its job. I have really good videos to kind of show this. Here's a YouTube link on this. I'm not going to click on it for time's sake because unfortunately COVID has a lot of slides. But it's there, and it's a really nice simplification of kind of what's going on. It goes over each of the classifications, so not just coronavirus, but it really does a good job of kind of explaining what it does when it enters the cell. Again, though, remember, two main goals. Viral proteins, replicate. I tried to take snapshots of the video to kind of showing, the two things that it wants to do. Again, it's coming with its mRNA already because it's a positive sense single-stranded RNA virus. It enters your cell from the ACE2 receptor. It then can go ahead and start making viral proteins, as you see in the top picture. And then it can also go down and start making the reciprocal copies of itself so that it can start making more of itself. And then it packages everything with the proteins that it made, exits the cell, causes the damage. A very simplified version of kind of summarizing what the coronavirus is doing when it enters the cell. And this is important because, and I talk about it because the drugs that we're going to be using, specifically the antiviral agents, are trying to target some mechanism of the reproductive cycle of COVID. So is it a protease inhibitor? Is it a nucleoside analog? These are all things it's trying to kind of do within this oversimplification of the picture to inhibit the replication or the making of the more viral proteins. All right, this one hits hard because I remember looking at this when it first happened. Is anybody familiar with the Johns Hopkins surveillance site? No? Okay. So okay, that was the first kind of global surveillance of looking at coronavirus and how many cases there were worldwide, nationwide. So if you notice, 245 cases. That was on March 2nd, I believe, 2000. Let's jump 3 years, right? Almost 3 years, a little over 3 years. That's when it stopped. So March 10th, 2023, it stopped updating. And that was the last numbers that we got in terms of what we're seeing with coronavirus worldwide. Unfortunately, in the United States, we were one of the leaders in this in terms of numbers, which isn't a good thing. It's not something we should be proud of, but it is what it is. And kind of talking a little about epidemic versus pandemic, and we get these words, sometimes we don't really know what they mean. So initially when COVID happened, it was a epidemic, right, in certain areas. That epidemic then went to a pandemic. It was similar, but globally. And then it's now transitioned to an endemic. You're seeing something that's going to be kind of seasonal. It's going to come, it's going to go. We're going to kind of be able to predict it based off of the weather, stuff like that, similar to the flu. So that's where we're at right now. another oversimplification, but we know that it's an airborne virus, similar to other SARS viruses. A little bit about, masking. I know there's a lot of controversy. Some people aren't happy about it, but it makes sense when you both wear masks, decrease transmission and decrease contraction, right? Now there is some controversy, but we'll talk about that in an upcoming slide. But initially, even though we know it was airborne, I like to brag about UNMC a little bit because we were the first to kind of show that, with research, with an experiment. And it was a colleague of mine, Sid, who actually showed that it is airborne and the particles are very small. And it kind of helped give some guidance on some strategies like ventilation and stuff like that to help reduce the chances of catching it in a room. So the mask dilemma, right? To mask or not to mask. Recently, the Cochrane Systematic Review, and they do a meta-analysis as well. It was recently published. It summarized the results of 78 randomized controlled trials, which are the leaders of our when it comes to research. We always want to look at randomized and meta-analyses. It showed that, kind of inconclusive. That is it beneficial? Is it not? Given the evidence, there wasn't really a clear answer to it. But if you ask me, I always say, why not play on the safer side? That's my recommendation. But always have to back that up with science. So let's talk a little bit about contagiousness, right? Sometimes we get this number, like the reproductive rate, R0. Anyone familiar with that? Each virus has one, but where does it come from? What does it mean? So if you look at this, again, this picture, that yellow is representative of a person who got sick, right? Got it from a source 0, whatever you want to call it. Those little red dots are the people that it infected. So notice that for every one yellow, it's infecting approximately 3.5 reds. So we'll talk a little bit more about that, but that's really where this is all coming from. And it's similar to influenza initially. I'm going to say initially because this is based on the wild type. As we got mutations in the virus, this number changed. So I like math, so let's kind of look at this all mathematically. Reproductive rate equals the secondary cases, which are the yellow dots you saw, divided by the primary cases, which was red, let me make sure my colors, the red dots over the yellow dots. So if R0 is greater than 0, that disease is potentially contagious. So if we use this picture, right, we're looking at 3.5 over 1, right? And if you look at that chart in the bottom, it says that SARS is approximately around 2 to 4. So it kind of makes sense, it matches. If the R0 is greater than 1, an epidemic is possible. And then always to consider, so what goes into this R? What are some factors? Well, treatment's a factor. So if you look at that boxes on the right side, you see the duration. If a patient is not symptomatic because they recovered, their viral load is going to be less. If they have less viral load, the chances of them giving it to somebody else is decreased. Then we have the rate. Coughing, masking, these are all things that can help, again, decrease the viral load that you're transmitting to somebody. And then efficiency, right? Temperature, humidity, things like that, environmental, that could contribute to the virus. Anything else here? Oh, and another important part. So you guys remember when we talked about that 60% vaccination back when COVID was first a thing? It all came from here. So on the right there, you see the math on how 60% is coming. So if you see is an R0 of 2.5, which was initially, then H equals 1 minus 1 over R0, which is 0.6. So that's where that 60% vaccination to get herd immunity came from. Now, unfortunately, that was never reached, and we kind of missed the boat on that. And if you look at the virus now, in terms of all of the mutations that it's had, Delta went to, 5 to 7? Okay, so it went from 2.5 or 2 to 4 to 5.7. And then Omicron is supposed to be 3 to 4 times as contagious as Delta. So I don't even want to think about what that R0 is at that point. But again, point here is that now we're at a point where this virus is very contagious. And what is it doing? It's mutating. It's mutating in the spike protein, making it stickier. It's able to attach to those ACE2 receptors a lot better. By the way, feel free to interrupt me if anybody has questions. I like to kind of make this a little bit more interactive if I can. Some of my students hate it, some love it, so I think it helps make coronavirus more fun if we're actually interactive. Symptoms, again, this has evolved throughout the beginning of COVID. There were some olfactory issues. People had loss of taste or smell. That's again because the virus can infect anywhere that has the ACE2 receptor. There's also some theories that the virus uses those methods to get into certain parts of the body, like through the nose and through the olfactory system. So here I like because it kind of compares the coronavirus versus the cold versus the flu, but really it's hard to kind of, you can't really describe one symptom for one virus. It's really, at this point, it's kind of gotten all disheveled together. More recently, I know with the Delta, a very distinguished sore throat has been a very common symptom. And I'll talk a little bit about my own personal case with coronavirus. I always like to bring in some examples, real life examples, because it helps hit it home. So diagnosis, again, the gold standard is going to be your PCR test. In your inpatient setting, if you're admitted because you're having trouble breathing, they're going to do a chest x-ray, and they're going to see if there's any yuckiness that shows up in that chest x-ray, as shown in that picture. There are some other tests we're going to talk about. There's the antigen test, which is really the most popular home test that everybody's using right now, which is tests for some molecule part of the virus. There's the antibody test, which I don't recommend, serology. And we'll talk about why the antibody test isn't really reliable and it's not even recommended anymore. So here's a nice summary of the different type of tests, the molecular test, specifically the PCR. Then we have the antigen test, which is like the rapid test that we have at home, that we got free from the government. And then we have the antibody test. And again, here kind of gives you the pros and cons of each. Let's just ignore that right side over there because I don't want anybody relying on an antibody test to test positive or negative for this virus. And we'll talk about why. And here's the recommendations from the NIH specifically, because I always like to refer to the NIH guidelines on coronavirus in terms of what they say. They agree with exactly what I told you guys. They recommend against the serology, and they recommend either an antigen or the PCR molecular test. The issue with the PCR test, not as much anymore, but initially when we were doing it, there was a lot of supply issues. I don't know if you guys experienced that in the hospital. I couldn't get plastic. I have a lab that I run, and I could not order plastic for my experiments because they were all back ordered and everywhere was shut down. So similarly to the PCR test, there were certain parts of the PCR test they couldn't buy. So they were batching all the PCR tests so they could save the kits. And by doing that, it took a really long time to get your results back. And that's why sometimes people wouldn't find out for about a week or 2 weeks. So remember I said serology is bad, right? Antibody test. Why is it bad? Well, it takes about, on average, 7, even 10 plus days to even potentially release antibodies in the presence of an infection. By that time, you might already have recovered. You might have been asymptomatic. So it's really not giving you a good indication if you're sick or not. And some people never produce antibodies in the presence of an acute infection. So then, let's say I have a sick elderly family member at home. I tested for the antibody, it was negative. I went there, they got sick because I had COVID, but my antibody test was negative. Well, let's avoid those type of situations. That's why always antigen or PCR. Antigen's great. There are potentially some false positives that you can get with the antigen. That's why the PCR is kind of the gold standard, way more sensitive. But again, it really depends on availability. And antigen test is great. Nothing wrong with it. So, treatment options for SARS. When I first made this lecture, there was nothing. It was all supportive care. We were looking at Paxlovid, Plaquenil and azithromycin, and there was the horse paste as well. It got kind of crazy for a while. Specifically, so I put the guidelines on there because it has a very nice summary of everything in terms of treatment, but I'm going to be focusing specifically on the pharmacological interventions. Nice summary of the drugs that I'm going to talk about, just here, kind of more of an FYI. Do you guys remember the monoclonal antibodies that were a thing for a while? Did anybody receive it? Not to get personal, but any experience with it? Does anybody notice that it's not very popular anymore? So does anybody know why? So every time the virus, exactly, I think I heard you say it's not working, right? So why isn't it working? So the virus is smart, right? We talked about how it's really creative and it comes already with its positive sense single-stranded RNA. So the virus mutates, right? Variants. Well, the variants, the spike protein changes a little bit. And I have a slide kind of showing that better. It goes from like a circle to a square. And by doing that, the antibodies can no longer bind to it. So they pretty much became ineffective. There are still monoclonal antibodies that are used, especially in the inpatient setting, but those are more specific for inflammation. So they're targeting the inflammatory biomarkers and not necessarily the virus. So the guidelines kind of break it down into two big categories, hospitalized and non-hospitalized. So any inpatient checks here? Okay, so some of these medications you might be familiar with or seen. Kind of going from up to down. So down is the okay patient, supportive care. Then we get down to the ventilation, the ECMO, and you notice as we get down, you're going to see more add-on treatment to therapy. The big one that was used for initially was remdesivir. Anybody have experience with remdesivir? Is it still commonly used in the inpatient? Okay. So not a bad drug. Didn't really show a survival benefit in the studies. I like to compare remdesivir to Tamiflu. Will you probably clear the virus sooner? Yes, potentially, right? Is there a potential survival benefit? Unclear, unknown. And then we get down, we get patients that require oxygenation, and then we get to the steroids. We talked about how, think about the treatments. Does it make sense? Dexamethasone, we'll talk about the studies on it, is recommended in patients that require oxygenation because it's shown benefit, it's shown survival benefit. So it's remdesivir then plus dexamethasone. And then as we get even sicker and sicker, we start seeing the NIBs and the MABs, right? I call those the immunomodulators, medications that are used to control the inflammation that our body is seeing at a certain time. So let's go for each of these medications individually. Here's a nice summary. We have our baricitinib, which is another immunomodulator. We have our dexamethasone, our steroid. We have heparin as anticoag, right? Just kind of a routine to prevent coagulation. We know that this virus does cause abnormalities in our coagulation, and there's a higher risk for clots. So we want to make sure that our patients are heparinized. Remdesivir is our antiviral agent that we're going to talk about. It is, I like to call it an inpatient drug, but you are going to see now that it's recommended in certain cases in an outpatient setting. But what do you think that requires? Exactly, infusion center. It's IV only. So give you, things to think about, pros and cons of using remdesivir. But it may be indicated in certain populations. We'll talk about that. Then we have our MAB, seralutamab, which is again an immunomodulator. It's a monoclonal antibody, but not against COVID, against the inflammatory biomarkers. Then we have toxalutamab and I can never say these words. Tofacitinib. Anyway, just NIBs and MABs. So remdesivir, what is it? Nucleoside analog. Adenosine interferes with RNA polymerase, so it's inhibiting termination of viral RNA transcription. Virus cannot make more proteins of itself. It can't make that envelope. It can't get out. It was studied initially in SARS-CoV-2. The data that initially was on remdesivir was in mice, but when COVID became a thing, it came back and it got its EUA. It was first used for compassionate use, but then it got its full FDA approval on May 1st, 2020. Its efficacy, again, I kind of mentioned it, kind of like Tamiflu, showed benefit in terms of time of recovery, but when it comes to survival benefit, the data really doesn't support it. The nice thing about it, though, is that it doesn't have too many drug-drug interactions. We'll talk a little bit about that. It's indicated, again, for the patients that are hospitalized that require oxygenation. The dose is 200 milligrams over 30 to 120 minutes for the first dose, so again, a little loading dose, and then followed by a 100 milligram IV dose for the remainder of the 4 days. Initially, when this drug was used, it was a 5-day treatment, but they reduced it to 4 days. Adverse effects, prothrombin time, transaminase levels, GI symptoms, increased ALT and ASTs. Drug-drug interactions, kind of unknown. There is potentially some P450, we'll talk about that with ritonavir, and some transporter 2G, PGP, but really unclear. Interestingly enough, it was being used very commonly with chloroquine and azithromycin, but there's a huge no-no on that because hydroxychloroquine will actually decrease the antiviral activity of remdesivir. So you could see it in the hospital, but it was kind of counterintuitive because it was working against each other. Monitoring will be hepatic and renal function, but I'm going to tell you that even with patients with renal dysfunction, that you're still seeing remdesivir being given. Kind of as a pros versus cons type of benefit outweighs the risk. And here's kind of the big one for it. It's really safe to use in pregnancy. Most nucleosides are fairly benign in terms of safety profiles. So that's one thing that we need to consider when we're using it, because some of the other drugs that we talk about aren't necessarily as safe in pregnant patients. Just a little summary based off the NIH. And then getting into our, in my opinion, like the star of the show in terms of survival benefit is our dexamethasone. It's a steroid. The first kind of data that showed the benefit of it was from the recovery trial over in the UK. It helped 1/3 of patients who ended up on ventilators could potentially benefit from this drug, at a reduction of death that was significant, approximately 20%, again in patients that needed oxygen. And the big take home here is that in patients that did not require oxygen, did not show any benefit. So going back to that slide that we had with the lung, just think about like inflammation, right? If they're not requiring oxygenation, there's probably not a lot of inflammation going on in there. So it makes sense that dexamethasone probably isn't going to do much for you in that patient population. Here's a little bit about the mechanism of action of what it's doing. Again, think of it as an anti-inflammatory. So notice that it's causing a delayed response and decreased COX-2 transcription and inflammatory cytokine release. So oversimplification of kind of a nice diagram of why it's being used for its anti-inflammatory properties. It's an agonist against the glucocorticoid receptor. So, once they found this, they started looking at other steroids as well. They repeated dexamethasone versus placebo. They found that there was a survival benefit. They looked at hydroxycortisone versus placebo. They found that there really wasn't a benefit. They looked at methylprednisone versus placebo. They found there really wasn't a benefit. So again, glucocorticoid is kind of the key here. And not all steroids are the same in terms of the benefit that you're seeing in COVID. So our immunomodulators, baricitinib is our gyrus kinase inhibitor. Again, just think of it as inhibiting trying to decrease the inflammation that's going on in your body. Indication, again, it's going to be in an inpatient setting, so those who require supplemental oxygen. This is a 14-day treatment. I believe it's PO, if I remember correctly. And it is for patients that require supplemental oxygen. And notice that it is dose-adjusted renally, so something to consider when you're giving it. Adverse effects, again, whenever you think of an immunomodulator, what do you think it's going to increase your risk of? Infections, right? It's going to be kind of like a nice way of, a nice broad statement you can make, is whenever you decrease your immune system in some way, you have an increased risk of other viruses or opportunistic infections. So not surprised that we have increased risk of respiratory tract infections, herpes simplex, zoster, and nausea, which has a black box warning for it. Now the next immunomodulator, again, this is a PO medication, a JAK inhibitor. Intracellular enzymes, again, controlling the inflammation process, indicated again in patients that are admitted inpatient and requiring oxygen. The dose for this is going to be 10 milligrams PO BID, again, is renally cleared, or up to 14 days or until discharge. And again, notice that adverse effects, very similar to what we talked about in the previous slide. Now we're getting into our MABs, right? Again, not to be confused with the monoclonal antibodies that target COVID. This is specifically monoclonal antibodies that target your immune system, inflammatory biomarkers. So there is a nice kind of way of remembering, I used to know it, what each monoclonal antibody represents. There's certain words and phrases in the name of the drug that kind of tells you if it's respiratory, if it's inflammation, if it's oncologic. But I knew it one time. I don't remember it anymore. And but you can find that chart online. Yeah. Each word, each part of that drug has a specific purpose in terms of what it means. Again, we're dealing with hospitalized patients with COVID who require supplemental oxygen with high flow device or non-invasive ventilation, which also does indicate as well for invasive mechanical ventilation and ECMO. The nice thing about the MABs, though, and this is I hate making blanket statements, but as a class, it's usually one and done. Long half-life, you give the dose via IV, no more dosing required. Unfortunately, though, whenever there's an IV, you need to kind of monitor the patient. There is like about a waiting period when the patient gets this drug to kind of make sure that they're okay to leave. And again, serious infections as a black box warning, because what are we doing? We're going against our immune system, trying to make sure that we're not overly active, right? Hyperactivity of the immune system is what's causing our respiratory distress in the lungs. Our next MAB, again, very similar immune modulator. It's binding to IL-6, another inflammatory biomarker. Again, it's just an alternative to the other one if not available or not feasible. Are you guys seeing these drugs used a lot in the inpatient setting or not? Yeah. And you'll find that like certain hospitals and sites will have favorites that they want to kind of stick to. Again, hospitalized patients that require invasive mechanical ventilation or ECMO. Nice thing about it, single shot, sub-Q, or it can be given as an infusion. You monitor, you wait 1 time, and similar adverse effects to what we talked about previously. Oh, and one thing to note that with infusions, site reactions as well is important to look out for. Now to our non-hospitalized patients. So much simpler, right? Not as many drugs to use, really only 3. Dexamethasone is not going to have, the steroid we talked about, there's going to be no utility here, because if it's an outpatient setting, they're probably not requiring oxygen, right? If they required oxygenation, it'd be admitted into an inpatient setting. So for this, we have about, I'd say 2 drugs, but we'll call it 3, just because that's what the NIH guidelines say. We have Paxlovid, which is a two-part drug. We'll talk more about it coming up. Nirmatrelvir, the antiviral component, and ritonavir, which is the booster. And we'll talk about why it's given with ritonavir. Ritonavir is really the problem when we're looking at it from a drug-drug interaction profile. Then we have our molnupiravir. Not my favorite drug. We'll talk about why it's not my favorite drug. It's an option. It can work, but we'll talk about a little bit about it. And then remdesivir. We talked about that, right? It's considered here as a potential agent for outpatient, but you're going to have a line in, right, infusion center. So things to consider. So molnupiravir is a oral prodrug, a ribonucleoside, has antibacterial activity. It came out after Paxlovid, so not a little bit after that. Again, it's indicated in non-hospitalized patients. The dose is going to be 800 POBID, up to or less than 5 days. Again, and now it's up to less than 5 days, but I can tell you that these durations are being studied in clinical trials to see if we need to prolong the duration of treatment to potentially decrease rebound COVID and other things that we're seeing that are coming back in some patients. But for now, it's EUA for up to or less than 5 days. I do want to note that this is not the preferred agent by the guidelines. The Paxlovid is still the preferred oral antiviral agent to be used. And that's why I kind of want to focus more on that for this presentation. Side effects, diarrhea, nausea, dizziness. It's not too bad. No drug-drug interaction studies, so physicians really like it, right? Because when we have our patients, our older patients on chronic medications, they'll have a lot of other medications that they're on, specifically medications that are metabolized by CYP3A4 enzymes. So with this drug, you don't have to worry about any of their chronic medications because there really isn't any significant drug-drug interactions. However, a big one in pregnancy, do not use. Studies have shown that it's actually been fatal to the fetus with fetal toxicity. So not a drug, not recommended in pregnancy. Again, just what I summarized just by the NIH guidelines. So I mentioned a little bit about it. Here's the data to kind of support what I was saying verbally about the monoclonal antibodies, specifically for COVID. So notice here we have a happy face. The antibody can bind to the mushroom spike protein, but then that spike protein started to change shape. And when it changed into the triangle, the antibody got a sad face. It was no longer able to bind to that spike protein. And that's really what happened with the monoclonal antibodies in a very simplified picture. And the data on the left shows as the variants started coming into the population, the monoclonal antibodies started becoming less effective. And that's just the data that the NIH summarized to show that. Now, even though I'm not trying to dig or to jab on monoclonal antibodies, I think they have a role still, specifically in our non-vaccinated population that can't get vaccines because of immunosuppression, like some of our liver transplant patients or oncological patients or just some hereditary immune dysfunction. They can't get specific vaccines given the virus. This is still potentially an agent that can be used as an option since there really isn't a vaccination solution to them. And these do have long half-lives. The monoclonal antibodies can last in your body for 100 plus days. Remember, it's a one and done type of situation, like I talked about. So going to the star of the antivirals, the Paxlovid, ritonavir boosted nirmatrelvir. So it's a protease inhibitor, and I can tell you from experience that it seems to be the most promising class for COVID are the protease inhibitors. There are other studies ongoing that looking at new protease inhibitors to be used for COVID, specifically protease inhibitors that don't need to be boosted with ritonavir. So ritonavir is being used here, and we'll talk a little bit about it because nirmatrelvir is a great drug and it works well, but it's cleared really fast by our body. It has primarily CYP3A4 metabolism, and what that means is that as soon as your CYP3A4 sees it, gets in the liver, it gets metabolized, it gets cleared. So what does ritonavir do? Ritonavir inhibits CYP3A4. So by inhibiting CYP3A4, you have actual therapeutic concentrations of nirmatrelvir. It's interesting that without the presence of ritonavir, you do not get therapeutic concentrations of nirmatrelvir in the body, and the data for that exists and is available. It is a little bit of the dose of this is kind of, it's a big pack. It comes in a dose pack. Is anybody familiar with it from an outpatient setting? It comes in a box. It has like a night and day, and it has like, I believe, is it 3 pills in each section? 2 for the nirmatrelvir and 1 for the ritonavir. So duration for this is, again, up to or less than 5 days. I can tell you that they are looking at extending that to be determined. The studies are ongoing to see if there's any potential long-term benefit for taking it for longer than 5 days, but what do you think the problem is there?
Compliance and cost.
It's not cost, but it's a good thought. So remember we talked about ritonavir, right? Major drug-drug interactions with ritonavir, and that's why physicians don't like it. Maybe we haven't mentioned it yet, but we will. So issue with the increasing in 10 days is that, well, what do we do with those chronic medications that the patients are on? And there are guidelines and recommendations on what to do on those, but when you're dealing with a 5-day course, maybe you stop that drug for 5 days, right? You stop that statin for 5 days, it's probably not going to be a big deal. But when you're dealing with a longer course, then we start, dealing with issues, and what are we going to do? Now, pregnancy, this is where it gets interesting. There was only one study, a clinical study that was done by Johns Hopkins. They looked at about 55 patients, and they found that it was safe, it was probably fine, but for some weird reason, patients that got Paxlovid versus those that didn't had a higher risk of C-section. So, something to consider, I know. Now, it wasn't significant, it was a small study, but when you're dealing with stuff like this, it's going to be small initially until those appropriate trials are done. And we'll talk a little bit about that in a little case example that I'm going to bring at the end. Again, similar to my other drugs, here's the NIH recommendations on exactly what I mentioned. Therapy options in pregnancy. I think it's important to talk about because it's come up a lot more recently, and it's good to know what options are available and what options are not available. We already talked about molnupiravir, right? We don't want to use that in pregnancy given the fetal toxicity. So with the NIB, it's the first one, the immunomodulator. It's recommended, but again, that's specifically for hospitalized patients, right? So a lot of these patients you're going to see that are pregnant are going to be in more of an outpatient setting. So what are our options? Well, our options are going to be remdesivir. We talked about that, right? Needs an IV line. Not sure if a pregnant woman wants to be dealing with an IV, having an IV line while they're pregnant. We have Paxlovid, right? Yes or no? We're not really sure what to do there. Dexamethasone is not going to be recommended in outpatient setting, right? Because it's only for patients that require oxygenation. So, things to consider when we're dealing with what options do we have in pregnancy. And we have our MAB option, but again, hospitalized in one time. So, and no data on that currently to kind of support that. Yeah, sorry, X. Try to emphasize the important parts in terms of questions that you might have for your CE credit. So, I talked a little bit about that, Paxlovid and DDIs. What do we do about it? Well, there's this thing, are you guys familiar with the cytokine P450 enzymes? Major family of enzymes. They're responsible for oxygenation in organic substances. They're found in viruses, bacteria, plants, animals. There's a lot of them, approximately 30 different types. But 90% of the ones that are used in the body are in that list. Specifically, the 2 major ones that are found are 2D6 and 3A4. And the one that's specific to Paxlovid, as 2D6 is in minor, the majority is 3A4. So 3A4 is what we worry about, and that's what ritonavir is doing, is inhibiting 3A4 so that nirmatrelvir concentrations can get therapeutic. So what do? They're activating, deactivating, and metabolizing compounds. They're used as a defense mechanism, so it's good to have them. There is some genetic links in terms of genotyping and are they poor metabolizers or fast metabolizers, and some medications are dosed differently if we know if they're a poor or fast metabolizer. So what do you guys think would happen if someone's a poor metabolizer? So they have less 3A4. What do you think would happen? So nirmatrelvir concentrations, right, would potentially be higher, or the drug that's being 3A4 would be higher. If you have an extensive metabolizer, you have more 3A4 than normal. Drug concentrations are going to be less than desired. So these are things that we consider when we're dosing the drug if we have this information available. There is an age component to it. As we age, there's reduced activity of certain ones as we get older, and also newborns. Their majority of expression of the cytokine P450 enzymes change as they get older, from infant to certain age groups. Again, I like oversimplified pictures. We have a patient here, box taking simvastatin, right? Or atorvastatin, we can call it any statin. We have CYP3A4 metabolism. Ritonavir inhibits CYP3A4 metabolism, so what happens? We get decreased elimination of the statin and increased bioavailability. What does that mean? We have an increased risk of toxicity. So that's why these are things that we need to consider when we're looking at this drug. And that's why, Paxlovid, some clinicians they're kind of scared to use it in an outpatient setting because you have to worry about these type of things when they have the ritonavir component of Paxlovid. So here's a nice chart of, the NIH actually makes it really nice, the guidelines, a chart of okay drugs to use with Paxlovid. So these are the okay drugs. I'm not going to go over this full list here, as you know, it's comprehensive. Something to note that this CYP3A4 inhibition by ritonavir happens pretty fast, within 48 hours of the ritonavir usage. And once it's concluded, 70-90% of it comes back within 2 to 3 days of the CYP3A4. So the point of this is it's acute, right? So, something to consider is it potentially okay to stop the chronic medication in this short duration of time, knowing that ritonavir is going to be gone, the effect of CYP3A4 within 2-3 days of stopping Paxlovid. So again, we talked about this. Ritonavir is an inducer of other drug metabolic enzymes and drug transporters. Given 5-day short treatment, not usually a concern from chronic medications. Right now, it's only authorized for a 5-day course. I know you've maybe heard stories of some people taking 10-day courses, whatever, but as of now, an FDA approval is only approved for 5 days. Now, they are studying on potentially looking at, is there a benefit of again, increasing that to 10 days or 15 days or a month, but as of now, 5 days. So contraindication, St. John's wort and rifampin, those two drugs really, those concurrent always get a bad rep, but it's because they're very strong inducers. So if you have a strong inducer, what happens? You'll have no neuromaterial concentrations, probably detectable because you have way more CYP3A4 expression than you'd like. Make sense? And you're kind of fighting against the ritonavir component when you're doing that. Again, just a nice summary of the different trackers that are available. We have the boxes, they call them box 1 or box 2, which is based on the NIH guidelines. There's a web-based drug-drug interaction, which is a great tool. It's a Liverpool. It's from University of Liverpool over in the UK. We have a lot of collaborators with them, they're great people. You put in the drug, and it can be any drug, not just COVID drugs, and it'll tell you the interaction and what to do with it. So I'll give you an example on a coming slide on a drug that we did that for to see what the recommendation was. And there's tables and guidance available by other universities and the FDA as well to kind of help us in terms of what do we do? Do we change the medication? If we're going to change the chronic medication, what do we change it to? Do we stop it? Do we do half a dose? These are the different options. So again, box 1, no interactions. I'm not going to go over all these medications, but they're here for your convenience. And box 2, drugs that are known for interaction. And unfortunately, you see box 2 is higher than box 1. So what are our potential options for drug-drug interactions? Well, we can, of course, monitor closely, right? See if there's adverse effects. Unfortunately, that's probably not going to be possible in an outpatient setting, right? They're taking it, they're going home with it. Unless the pharmacist or someone checking up on them while they're home, you're probably not going to be getting real-time what's going on with that patient, updates. You can decrease the dose by 50%. That's a popular method as well. And again, it'll give you specific recommendations, but sometimes if it's an extended release tablet or if it's hard to cut, that might not be an option. And I think that probably the most popular method is to alternate the days. So you take the drug every other day. And that's probably the most popular method that I've seen people do for this. Or using an alternative COVID therapy. Some clinicians will do that. Instead of using Paxlovid, they'll go to molnupiravir as long as the patient's not pregnant. But again, based on NIH guidelines and my personal recommendation, I think that Paxlovid is a better drug in terms of treating COVID than molnupiravir. But if you don't have an option, you don't have an option. So here's an example of that Liverpool tool that I talked about. You put in the drug. So here I put in atorvastatin and Paxlovid. It gives you a nice interaction summary. Co-administration is not recommended unless specifically required. It gives you a recommendation on what to do. It says that because it's a short treatment, you should stop atorvastatin. And then you said restart it 3 days after the last dose of nirmatrelvir. Again, and this is all in line with what we talked about with the CYP3A4, right? It happens really fast, within 48 hours, and then it goes away within 2 to 3 hours, 2 to 3 days after the completion of the drug. Same thing as before, kind of showing that that's kind of in agreement with what the Paxlovid, the Liverpool recommendation tool says. So I highly recommend, again, there's no, I'm not getting anything from it. It's a free software. It's really great. I use it all the time. So let's talk about a case that kind of hit from home. I was recently at it's CROI, it's a virus conference. It's an HIV COVID conference over, and was it Seattle? No, yeah, Seattle, Washington this year. And I did wear a mask the whole time, as it was required. Dr. Fauci was there. He gave a nice talk because he was initially an HIV researcher. I don't know if a lot of people don't know that about him. Took a rapid diagnostic test, was negative. Wear a mask the whole time. But I noticed that when I got home from the virus, from the virus conference, and even on the plane, I felt a sore throat. It was coming on, and it was kind of a very severe sore throat. And I just felt kind of like really weak and fatigued. Took a test, it was negative. Took a temperature, it was 99.4, so like low-grade fever, right? Not necessarily, in that borderline. Maybe somebody even say you're not febrile at that point, depending on what criteria you're using. What's going on here? But, I had a feeling, right? If it looks like a duck, if it quacks like a duck, it's a duck, right? And being in this COVID world, I was like, this really feels like COVID, from what I've seen, what I've heard, and what I've read about. So, unfortunately, or fortunately, but I'll say unfortunately because she was pregnant at the time I got this. She's still pregnant, late first trimester, my wife, beautiful wife. I didn't want to expose her to the virus. I knew, I was like, I'm getting sick, so what did I do? I called my infectious disease fellow, who I'm a colleague of mine. I said, hey, can you give me a prescription for Paxlovid and Augmentin? Because my test was negative, I had no idea. I wanted to cover my bases, right? I didn't want to get her sick. That was the goal of all this. She's pregnant. The studies are very unclear on the effects of COVID infection in pregnancy, and it does differ by trimester. So first versus second versus third, there's different risk factors associated with it. So, and again, both are fully vaccinated with boosters and the bivalent. So 2 shots a booster, 2 shots, a booster of the first version and the bivalent new shot. So I put myself on Paxmentin, I call it, right? A little combination of a little play on words there. In the hospital, techs might know of vancomycin, right? Everybody gets on vancomycin and Zosyn. So got myself a Paxlovid, started taking it. What happens on day 2 of Paxlovid treatment? Test is positive, right? So again, early treatment, that's the key with these antiviral agents, because this course of COVID is very short, right? We're dealing with a 5 to 10 day symptom onset and recovery. So you want to get on medication as soon as possible. If you have COVID, you're day 3, it's probably too late. I probably wouldn't bother at that point. You can, right? But the benefit you're going to see is really with early treatment. So being in this world, I was like, all right, I'm going to get on early treatment. I'm going to prevent my wife from getting it. Tested positive. Unfortunately, she got COVID from me. I wore a mask the whole time. I lived in the basement for that week, but still, again, we're dealing with the Delta, right? We talked with the Omicron, right? Which was 3 to 4 times as contagious as the Delta. And the Delta R0 was, 5 to 7? So we're just dealing with we're going uphill, right? There's just really nothing we can do. Unfortunately, she is also on a mini medication she has a family history of hypertension. And she's on a calcium channel blocker, nifedipine. So what do we do? Well, what are our options? First off, do we start treatment with her, right? The data in pregnancy is limited, right? We know that we shouldn't use molnupiravir, right? Fetal toxicity. So what our options are, Paxlovid or remdesivir with an IV line. I don't know about you guys, but my pregnant wife was not very thrilled about having to get an IV line in her and going to an infusion center to get remdesivir. Also, on the same note, she wasn't happy about a potential increased risk of C-section delivery because of Paxlovid, right? So what do we do in this situation? Kind of outweigh, cost versus benefit. So just a kind of a question, maybe no right answer here. What do we start her on, right? What would you guys do? Yeah. Could we do remdesivir? We could, right? IV line. Could we do the baricitinib? We could, but remember, what's the key about that one? It's only indicated in hospitalized patients that require supplemental oxygenation, right? So she was fine, mild symptoms, really nothing going on from an oxygenation standpoint. But we're not going to do molnupiravir, right? Great, yeah, good. So, but what do we do about our hypertension medications? Let's say we started Paxlovid. Right, what's wrong with Paxlovid? We have a CYP3A4 inhibitor, the ritonavir component. Nifedipine is cleared by CYP3A4, of course, because when it rains, it pours. So what are our options? We can stop duration during COVID treatment. We can reduce the dose by 50%. We can take the medication every other day, or we can switch to another hypertension medication. So what do you guys think we did? Stop duration, okay? AC. So A is with hypertension, it's a little bit trickier. With statins, it's probably okay to stop it for a couple days, but with hypertension medications, a little more of acute changes. We don't. Depends on who you ask in terms of if that would be a recommendation. Reduce the dose by 50. We could have done that, but I believe it has an extended release tablet, and you never want to mess with that with the tablet in terms of that, unless it's recommended, unless they say it's okay to do it. So I personally I think that the C would have been the right answer. But again, A and B are not incorrect, and C and D is actually probably not incorrect either. But probably a lot of work to kind of switch her on to something else, and then let that become therapeutic just to kind of switch her back, right? Because you can't use all medications during pregnancy for hypertension, right? Like ACE inhibitors are contraindicated in the first trimester. Right? So things like that. So what did I do? Well, let's go to the Liverpool tool that we have. We put Paxlovid and nifedipine, and look at that recommendation. You can decrease the dose by 50%, or you can give the dose every other day. So she did not take Paxlovid because, again, she did not want to be at risk for higher risk of C-section and early pregnancy, and that was what that small study showed. But these are things that we consider when we're dealing with these kind of drug-drug interactions. But I kind of like this case because it kind of brings everything together in terms of a real experience and things that I went through. I got better, but it was pretty bad. It hit me pretty hard for that week that I had it. So thank you, and this is it's my little family here, my boys. And at that time, I'd like to open it up for questions. Yes.
Thank you, Dr. AAPT. That was a great presentation. As a prescriber of Paxlovid, obviously brand new med, I don't know a lot about it. Frightened of it. You're exactly right. We're really reticent to use it because of those interactions. How much? I usually rely on the pharmacy to help me out with it.
Yeah.
I'll order it. You guys kind of look up. I kind of rely on you guys.
Yeah.
Look up the interactions. I hope that's appropriate. You guys help me out.
Yeah, no, that's great. That's always, I want to say that I hope that the pharmacist who's dispensing it will catch that medication. I think it pops up normally on the machine, on the kiosk when you put it in there. But there are really good tools now available. When this was first a thing, 3 years ago, everything was just an unknown. It was like a rat race. We were looking at all sorts of therapies as potential options. Things have gotten a lot better, and I think they are going to still get better. I think COVID's kind of changing. It's not really more of an acute infection anymore. A lot of the studies is kind of going more to a chronic infection in terms of some of the underlying side effects that we're seeing in patients that are recovering from COVID. So I think that's where a lot of the push is now. The protease inhibitors do seem to be working really well. There are drugs coming up, I can tell you, in the pipeline that do not have ritonavir, so no need to be boosted, and then thus no reason to worry about drug-drug interactions. Yeah, great question though, and great comment, thank you. Yes?
So the drugs you just mentioned coming up in the pipeline, are they new drugs that are coming out, or
Yeah.
drugs that currently have that are being used for it?
Yeah, great question. So the question was, are they new drugs or are they kind of rebranding an existing drug? So these are new drugs, new antiviral agents that Pfizer, Merck, AstraZeneca, they're all kind of looking into. Yeah, follow up.
Are they covered by the government, like Paxlovid is currently? Or like,
That's a great question. I don't know the answer to that. I don't think it will.
I could buy for the pharmacy. So.
Yeah, no, that's a great question. I don't know.
Okay.
Yeah. Great. Well, thank you guys. It was a pleasure. I hope you guys enjoyed it. And